Yeah, good morning, everybody. Good morning, Luis. Thank you for inviting us to Madrid, and thank you so much for organizing this meeting. Luis asked me to talk about the risk profile and the complications of using flow diverters for intracranial aneurysms and other intracranial lesions. And my colleagues did a great job in just number crunching all the complications we encountered, and that's what I will show you during the next couple of minutes. So we obviously treated 830 patients with flow diverters. We started actually in September 2009 with probably one of the first pipeline cases done in Germany. And between this September 2009 and December last year, we did 1,096 procedures with in 830 patients, and those 830 patients had 952 target lesions. We used 740 P64 flow diverters. In 315 patients, we used pipeline. So we started actually with pipeline and continued with P64. We are still using both flow diverters, but we are using more P64 than pipeline. We had 53 combinations of pipeline and P64, which is very good if you need an instantaneous, very significant flow diverting effect. It's good to combine these two devices because you have this phenomenon of non-matching patterns of the two flow diverters. So if you combine both different devices, you have more effect than just putting two of the same kind. And we had 14 failed attempts. Most of those failed attempts were early in our experience. A failed attempt today is literally no more an issue, and all these failed attempts were related to friction issues of the either pipeline or P64 within the microcatheter. We did flow diverting treatments in 600 saccular aneurysms, 461 with P64, 122 with pipeline, 9 combinations and 8 failed attempts, 270 fusiform aneurysms, 125 dissections. The flow diverters are actually in Germany reimbursed for dissection. So if you write dissecting aneurysm, that's a code where you get full reimbursement for using flow diverters, which is, I think, different from some other countries. And we used flow diverters for CC fistulas in all kinds of acute occlusions, maybe due to dissection or other reasons. And in a few stroke cases, we used when we were unable to get the thrombus out of the internal carotid artery. We used the flow diverters simply to fixate the thrombus in the ICA, which is non-reimbursed, by the way. The analysis was done in retrospect, of course, and we did it per procedure. So the counting was a kind of a counting oriented on the single procedure, and any complication of potential significant occurred in 12% of the P64 procedures, in 16% of the pipeline procedures, and in 21% of the combined cases. These numbers are not kind of real safety margin numbers. So as I said, we started with pipeline, so the 16% complication rate with pipeline are certainly related to our learning curve, and the 12% of P64 doesn't necessarily say that P64 is safer than pipeline. It just said when we started with P64, we had way more experience than it was the case when we started with pipeline in September 2009. And the 21% of the combined cases simply reflects that these are more complex, more dangerous, and technically more demanding cases. We try to differentiate things happening during the procedure, in the first 4 weeks after the procedure, and in the long-term course of these patients. So the event rate during the procedure was 5% for P64 and 6% for pipeline, quite similar numbers. During the first month, 4 and 6%, and in the long-term follow-up, 3 and 5%. The far majority of these cases, and I show you a series of examples, the far majority of these cases are ischemic events. So the rate of real hemorrhagic complications is quite rare. The issue with flow diversion is not really a hemorrhagic issue. It's more or less, I would say, 90% ischemic problems. Overall morbidity and mortality, the permanent morbidity, serious morbidity rate is 2.3%. 19 patients experienced a permanent neurological morbidity related to the flow diverter treatment, and the mortality is 1.9%, 16 out of 830. We started with a traumatic case. This was actually the first pipeline case we did in September. This was a large supracloinate aneurysm. She was referred from a neurosurgeon. He had tried to operate on the aneurysm and couldn't clip it. We coiled the aneurysm and put a pipeline over the neck of the aneurysm. This was technically very straightforward. There was nothing special. It was just putting coils and putting a flow diverter. And we had actually no real experience at this time, so we didn't know anything about post-medication, so we just put the patient on heparin as long as she was lying in her bed, and we put her on dual antiplatelets, and we were quite pleased by the result. This was 4 days later. She came back, this was on a Saturday. This was the first day without heparin, and she had a massive intraventricular hemorrhage. We did an angiogram, and at this point, no heparin, no steroids on board. You could see this little contrast stain coming from the dome of the aneurysm. That was the point where the aneurysm had ruptured, and the patient eventually died from this rupture. Many of these complications we encountered are a combination of, I would say, bad luck, operators, failures or mistakes. And this is a typical complication of this kind. It's the patient came with a symptomatic cavernous carotid artery aneurysm with a CC fistula from the aneurysm to the cavernous sinus. The treatment was literally straightforward. It's P64 flow diverter put in the internal carotid artery. The patient was discharged and came back a few days later with the emboli. He had a dissection related to the guide catheter and severe dissection of the internal carotid artery, and we put a stent over the dissection, but meanwhile the patient had experienced a massive stroke on his dependent hemisphere from which he died. This is another surprising case. The patient came for a megadolectatic basilar artery. We treated, which was symptomatic. She had a progressive tetraparesis. We treated her with flow diverters, which was technically easy. And we were when we finished the procedure, we were in kind of a hurry because we were encountering a series of emergency cases coming at the same moment. So we were probably too quick in closing the puncture side of the groin. She had a massive hematoma from the puncture side, needed blood transfusion, and apparently the blood transfusion, the transfusion of blood without aspirin and Plavix in this blood instantaneously caused a thrombus formation in the flow diverters and in the basilar artery, and she died. This is the image before, the ectatic basilar artery. These are you may see them, it's a little dark, I guess. Flow diverters in the basilar artery immediately after. Then she hemorrhaged and came back from the operation theater. She didn't actually wake up from the operation of her groin hematoma. She was brought back to the angio suite and had this massive ischemia of the cerebellum and apparently the basilar artery was occluded. This is about 2 hours after putting the flow diverters into the basilar artery and giving her blood with thrombocytes without inhibiting their function. The basilar artery is apparently occluded. We did aspiration thrombectomy, which was technically easy, but we were simply too late. I mean, when we came and did the thrombectomy, there was already established ischemic damage of the brainstem and cerebellum. This is the image before. This is after. Technically straightforward, very easy thrombectomy from the basilar artery, but I think it's a matter of minutes. If you are not really there when it happens, you have very little chances to rescue the patient. This is after after the thrombectomy, she bled into the posterior fossa and died from this. Collateral damage. This was a man with a large cavernous aneurysm. He came with severe headache. He had cranial nerve palsy as well, but his main personal problem was severe headache. We treated the aneurysm, and I gave him a clear schedule how to fade off the steroids, and he kind of got used to taking the steroids. Whenever he felt bad or had headache or something, he just took steroids by himself, to the point when he developed severe immune deficiency and died from pneumonia. So this is the aneurysm. Easy treatment, coils and flow diversion, no big deal, and he just died from kind of incidental immunodeficiency induced by the steroids. Poor anti-aggregation may happen if the patient is taking the Plavix and the fractionators in Germany have a tendency to replace Plavix by clopidogrel salt. And the issue is that this generic clopidogrel salt is not inefficient. It has a complete different acting profile, so the patient can be under-inhibited, over-inhibited. You don't know. It's kind of giving a different drug. It has the same name. It is clopidogrel, but the efficiency is completely on an individual basis. It's completely unpredictable. The patient being just right on Plavix can be completely over or under-inhibited if it's replaced by the generic drug. This was a lady with this dissecting aneurysm of the basilar trunk, the pipeline, P64 in place, everything is fine. She went home, and the same week the fractionator replaced the Plavix we had given her by the generic clopidogrel salt, and this is 1 day after, and 4 weeks after, she slowly had TIAs and they didn't react. They said, this comes from the flow diverter, and they didn't neither test nor send her to any MR imaging. So she had recurrent TIAs, had this pontine infarct. When she came back, she was literally uninhibited from despite she was under 75 milligrams of clopidogrel salt. And the aneurysm fortunately was gone. And surprisingly, she recovered from modified ranking 3-1. Which was just lucky. I mean, she had a real severe pontine infarct related to the fact that she was uninhibited for Plavix or clopidogrel for a couple of weeks. Those are the monsters. When we started, we were kind of hypnotized by using pipeline. We just couldn't stop, so to say, and this is one of the cases. Symptomatic megadolichy or ectatic basilar artery, and we started putting pipeline after pipeline. We just liked it, and it was a fantastic technique putting the pipelines, and we ended up with 18 pipelines, one telescoping, one inside the other, and we felt quite good. We liked the picture, we liked the procedure, and it looked great. And if you look, this is the 1st of July, and the 2nd of July, the image looked fantastic. The ectatic artery was literally reconstructed. Unfortunately, we had significantly changed or completely changed the hemodynamics of the brainstem, and there is no more flow from the other side. We failed to early on obliterate the left vertebral artery, which was only one of many mistakes in this case. And these 18 pipelines induced a massive and eventually fatal pontine infarct in this patient. This was one of the first patients we did in this pipeline trial. We used only pipelines and put one inside the other. It was growing, as you see here, the aneurysm growing between 2006 and 2013, so it was a real indication to treat the patient. And we telescope pipelines, not 18 in that case, I think it was only 4. August 2013, 4 pipelines, one inside the other in 2013. And this is the separation. So this, at this point, it was just an ectatic basilar artery. And the pipelines foreshortened and separated and caused kind of a inverted hemodynamic infarct, blowing up the aneurysm and creating this ball of the basilar artery. The patient came because he was very symptomatic. He was unable to swallow and was rapidly progressive progressive tetraspastic. We closed the gap and reconstructed the basilar artery, and the patient fortunately recovered completely. So the mass effect on the brainstem was completely reversible, and the patient is still doing well. This is later on. Closing the gap, closing the other vertebral artery. Yes, we know they really do need dual anti-aggregation, and this was he was a guy from France. He came for treatment to Germany. I spoke to him in German and French, used a translator and explained everything to him. And this is before and after this series of dissecting atherosclerotic aneurysms of the basilar artery and the posterior cerebral arteries. We were pleased with the result. He came for follow-up, and I explained that the majority of the aneurysms is gone away. It's obliterated, thrombosed, nice reconstruction, and he completely misunderstood me. He literally left the hospital, threw all medications away, understanding I'm cured. So he was just out of his mind, threw everything away, and died the day later just from having a basilar artery thrombosis. Similar story, large basilar artery. The widow of the patient said, you know, our source for beer is 600 meters away. He was able to walk 400 meters. So he went to the vascular surgeon for peripheral atherosclerotic disease. He went to the vascular surgeon and said, do something for my legs. I want to walk 600 meters. And the vascular surgeon did operation on his lower legs and his peripheral atherosclerotic disease. We were quite pleased with the result. The vascular surgeon, without any reason, stopped the anti-aggregation. He said it's not really necessary, it's overdone. And he came back with massive thrombosis of the basilar artery, and eventually died from this, and had this massive stroke for no reason. And it's maybe a good idea to put a tattoo on the patient saying, please don't stop aspirin apply, continue, whatever it takes. We learned a lot about the interaction of drugs. This was a large basilar artery aneurysm with the ICA rapidly growing, with the ICA originating from the aneurysm sac. This is the origin of the right ICA. And this is within a few months. This is 24 millimeters, 27 millimeters from October 2014 to April 2015. This is before the procedure. You see the aneurysm sac and the ICA coming from the aneurysm sac, and the plan was to put a stent over the aneurysm, put a few coils, and go for flow diversion. And this is the immediate result, a few coils in the aneurysm. We quite like to put a few coils because we learned that putting coils just interrupts the circulation of blood in the aneurysm, so it simply accelerates the process of So it enhances the process of flow diversion. We were pleased. This is a discharge, 20th of April 2015, day prior to discharge, and this was the post-medication schedule we had given to the patient. We said you should take 100 aspirin daily in the morning, and you should take Brilic, and we give you monoembolex and everything, and you should take ibuprofen only in the evening. He had before that he had a ventricular shunt, and he was used to use ibuprofen because he had headache after he had the ventricular shunt. And the plan was taking aspirin in the morning and taking ibuprofen in the evening. And these are the multiply tests after just after the loading. We have dual anti-aggregation. This is after the treatment. We gave some integralin during the treatment, so we have kind of triple anti-aggregation, Plavix, aspirin, and integralin. And this is after ibuprofen. You see with the ibuprofen, this is 18th and this is 24th of April. After the ibuprofen, he has no more action of the aspirin. The ibuprofen, he took ibuprofen against our advice in the morning together with the aspirin because he had severe headache, and the ibuprofen instantaneously antagonized the action of aspirin. He came back with this immediate thrombosis of the basilar artery and of the flow diverters. We aspirated, went for aspiration thrombectomy, which was again easy and successful, but just too late. This after the aspiration thrombectomy. And this is the fatal pontine and cerebral infarct. This is the key paper describing this relation. If you give aspirin and in the same moment either ibuprofen or metamizole, you may observe an instantaneous antagonization of the aspirin effect. So the patient has no longer an dual anti-aggregation. Sometimes we see quite unexpected flow diverting effects. This was a lady with this huge basilar artery aneurysm. You see here most of this was thrombosed. We were scared by the possibility of having an increase of mass effect by the aneurysm after putting flow diverters. So we asked our neurosurgical colleagues to put a ventricular drainage in this lady, which was done, and this is the ventricular drainage, and done under aspirin, and this is the next day, this complete thrombosis of the basilar artery just after, and obviously induced by they did nothing, they didn't change anything with the medication, they just put a hole in the head and put a tube inside, and the basilar artery thrombosed, surprisingly without any severe effect. She was a little drowsy for a couple of days and had nothing else, no neurological deficit. And the reason is the picas are filled from below, the basilar artery is filled through the PCOM, and the patient this is 2 years ago or even longer ago, the patient is still alive and well, and we put coils into both the 4 segments in order to avoid recanalization of the aneurysm, and put her on, this was recommended by one of our neurosurgical colleagues, we put her on, I think it was Avastin, a medication against vascular neurogenesis, and the aneurysm is not growing, and the patient is surprisingly good. This is 2014, 2015, aneurysm thrombosed. We see quite a number of instant stenosis. This was a lady, she had a subarachnoid hemorrhage, was operated for the subarachnoid hemorrhage, and she had an aneurysm here. You may see the clip here. And the neurosurgeon who operated on her said, I clipped the aneurysm, but the aneurysm didn't bleed. She had the bleeding was coming from the blister, and I couldn't clip the blister. So the blister aneurysm, which was the real source of her hemorrhage, was here. This is the clip on the innocent aneurysm, and this is the flow diverter for the ruptured blister. And this is 2013 and 2015. You see a significant instant stenosis. It was asymptomatic. It's just for the reason of showing the course. This is an interval of 2 years with this intimal hyperplasia. We did nothing, just continued with the dual antiplatelets, and as you may see, the intimal hyperplasia resolved by itself. And we now understand that quite a difference from a regular stent we use in intracranial atherosclerotic disease. Putting flow diverters may result in having this instant stenosis. It is most likely not real intimal hyperplasia. We had one case, I couldn't find the image, we had one case with this intimal hyperplasia, and she had a coronary issue, and the cardiologist gave her a glycoprotein 2B3A antagonist, and the intimal hyperplasia resolved within 1 day. The instant stenosis resolved within 1 day, so it's most likely rather thrombus than real intimal hyperplasia. I personally think it's kind of a layer of thrombus inside the flow diverter, which may explain why it usually goes away by itself. So to summarize, unless you are working at Lariboisière, I think the complication rate with flow diverters is low, and we have very good safety profiles. And the far majority today are more or less ischemic issues, if we forget about incidents like vessel hemorrhage, vessel perforation, or other stupid things. The main issue with flow diverters today is our ischemic problems, and I think within a year or two we're going to see real coded flow diverters which may overcome this issue. Thank you very much. Luis, say something smart.
Any question?
Since you have a vast experience with P64, my question is, any difference in terms of instant stenosis between P64 and pipeline? In terms of occurrence frequency?
To be honest, I can't tell for a very simple reason. When we used pipeline, we did angiographic follow-ups after 1 and 2 years. And for regulatory reasons, we were asked by the German notified bodies to do angiograms in the first years, which we usually did not with pipeline. So we have no real idea what happens with pipeline. I have a clear idea what happens with P64. With P64, we do follow-up angiograms after 3, 9, and 24 months. We see, I would say, something like 15% of all kinds of instant stenosis, and I don't remember a single case where the vessel occluded from this instant stenosis. It usually goes away. No matter how severe it is, it goes away for any reason.
15.
15.
At 3 months, or because you
between 3 and 9.
Between
3 and 9 months.
So
you see at any point.
So you encounter on your 9-month control angio rather sporadic fashion. I mean, yeah. Asymptomatic.
Usually asymptomatic, and in the very beginning, another difference is when we saw any kind of instant stenosis with pipeline, we were scared. We put a balloon and dilated the pipelines. Now, since we know there is no reason to go for this kind of balloon dilatation, we don't do it with P64. Another difference. So
okay.
Yeah, we don't do any angioplasty unless the patient is symptomatic, and we had not a single symptomatic patient. We did in a child with a dissecting aneurysm, we did a balloon angioplasty in a combined P64 and pipeline case, because we thought it may be difficult for the parents to understand that the boy is symptomatic or not with his instant stenosis. It was severe instant stenosis. And we did no other treatment in P64's instant stenosis. My gut feeling is the frequency is probably a little higher than with pipeline.
Thank you.
Thank you so much for the presentation. A quick question. You mentioned on the fusiform basilar aneurysms, the hollow basilar aneurysm, that if you had to go back, potentially use less devices and maybe also take the contralateral vertebral artery. Now, I think that there is some discussion to be had, because in that case, when you had multiple flow diverters in one, I think maybe the one open vertebral artery was actually the smart strategy to allow some progressive thrombosis of the aneurysm sac. If you had taken the vertebral artery from the beginning, I think there's no flow to that. This prefers to thrombose even faster than what you saw, I would argue. So I was just curious to see your approach today. Why would you change? Do you really think that was the main reason? We tend to wait and do a staged occlusion of the contralateral vertebra only if it fails.
Yeah, absolutely. You're right. So today we have way better results, and we are using less devices. We are staging the procedure, and as you say, we wait for 6 weeks before we take the contralateral vertebral artery away. And I think the most critical point is that you apparently have to combine antiaggregation with anticoagulation in these patients. So we see way less ischemic complications since we combine dual antiaggregation with giving direct anticoagulants. We usually give Pradaxa to these patients for 3 months in combination with dual antiaggregants and have much better results.
Excuse me, Olivier Lévrier from Marseille. Do you give Plavix and aspirin for life for the patient treated in the anterior circulation?
We give, if we use, let's say, 1 or 2 devices, we give dual antiplatelets for 1 year and aspirin forever. If we have these mega constructs, we give dual antiaggregants forever.
Thank you.
Thank you, your paper, your revision. But in our opinion, it's different, totally different, the arteriosclerotic aneurysm or dissecting aneurysm in the basilar territory with another aneurysm. In our experience, I don't use the flow diverter in this type of aneurysm. It's contraindicated because you have many complications. Since you are a big series, you only analyzes the basilar dissecting or basilar arteriosclerotic aneurysm, or is the complication of flow diverter is very high. I prefer to start to use test occlusion of the basilar artery. I have 7 cases of total occlusion of basilar artery is the first choice, and the second choice is to use the standard stent, soft stent, Leo stent or neuroform stent. Why? Because you are less radial force in the wall, and you are less complication in the evolution. I want one question is in acute complication after deploying the stent in this dissecting or arteriosclerotic aneurysm. Is acute complication is to secondary to mass effect to the brainstem or ischemia in the brainstem? What is the reason?
So coming back to the first argument, we had seen, I mean, we started, as everybody, we started with regular stents, putting Leo stents or any other kind of telescoping stents into these ectatic basilar arteries. And in the far majority of cases we followed, we didn't see a real impact of this kind of treatment on the course of the aneurysm. If you put, at least in our experience, I would say if you put telescoping stents, a significant number of these patients just continues to deteriorate and the aneurysm continue to grow. So you don't, if your goal is to interrupt the growth of these saccular components of the megadolic ectatic basilar artery, if the goal is to interrupt the growing process, the just putting porous stents may fail. The acute complications in the far majority of cases we had seen with flow diverters are very ischemic, so just obliteration of perforators to the brainstem. I remember 2 or 3 cases with rupture of the basilar artery aneurysm, fatal rupture of the basilar artery with stents. And all of these cases had in common that we kind of created a flow diverting effect by putting numberless Leo stents in the basilar artery and created the effect that is known today from large aneurysms treated with flow diverters, just having too much thrombus digesting the aneurysm wall and creating the rupture.
You are, in your experience, you are more complication with a standard stent or flow diverter stent in this type of aneurysm?
No. I mean the flow diverter is the sharper sword. If you use flow diverters, you have more effect and you have higher risk. But if it works, the effect can be fantastic.
I think another different solution, well, another evolution with aneurysm with the standard stent is because you use the very long stent, more than 50 centimeter Leo, and you have the possibility to change the flow in the origin of the vertebral, and then you're going to very far.
Sure.
And this is change the flow and slowly, and you are less complication.
Sure. The flow effect, the longer the stent, the more impact on the flow you may expect. The longer flow diverters, we try not to use long flow diverters for all kinds of twisting issues and stuff like that. So the use of long stents is certainly a good aspect.
What is your experience using P64 in acute phase of subarachnoid hemorrhage?
Yeah, we have not done so many acute aneurysms. All these aneurysms were done because they were either just unclippable or our colleagues failed to clip the aneurysm. We did probably a dozen of cases. None of these re-ruptured. And we had no serious issue, and it's pretty much the same. When we had only pipeline, we used pipeline for acute dissecting aneurysms with the same result. So it's apparently surprisingly safe.